All right, let's talk about this mindset. We've been doing a series of podcasts on macular degeneration, and historically, I think we've thought, hey, dry, non-exudative macular degeneration is mild disease. Wet macular degeneration is severe disease. But even that core mindset, we probably need to start rethinking. So how would you feel, or if you're talking to an optometrist, how would you kind of convince them that dry macular degeneration is actually still potentially very severe?
Yeah. So the more you understand, the more you realize about things, the more you realize as well, too, when we start seeing clinical signs of things, there's been a process that's been occurring for several years in these patients. So where we used to say, I remember describing confluent or intermediate sized drusen as soft drusen. That's kind of what we used to say. And we used to think, all right, this increases risk of going to wet AMD. But when you didn't have true treatments for wet AMD, or even when we didn't understand what to do for dry AMD, we always had to kind of somehow clinically put it into categories. So we'd always say, oh, yeah, if you're not leaking, if there's no hemorrhaging, if there's no neovascularization, that's mild. If you're more severe, or if you're leaking, that's wet. There's always this kind of lingering category of macular degeneration that not a lot of just the general community talked about because there was nothing we could do. It was actually the most frustrating form of macular degeneration that we had, and that's geographic atrophy. And that is really nothing more than long-term tissue destruction in individuals that have been compromised. Their macula is not functioning the way that they're supposed to. And now the tissue is responding by literally killing itself off. And this is a problem. And it's literally reframed the way that we're thinking about these patients. I've had more people in the last year, healthy individuals, ask me about my mother or my father or somebody in my family has macular degeneration. What can I do to make sure that I do not get this? And I love that conversation because I always tell them an ounce of prevention is worth a pound of cure. And I give them the guidance. And there's really three that I give patients. No smoking, good UV protection, and make sure you're increasing your dietary intake of lutein and zeaxanthin. And I tell them exactly where it's found. Dark green vegetables, kale, corn, spinach, orange peppers, corn, and egg yolks. That's where those micronutrients are just found. If there are additional concerns, we actually sell high doses of lutein and zeaxanthin in our practice. And we also have a way to measure those levels through macular pigment optical density testing as well, too. But again, there is unfortunately this kind of blurring of lines between mild versus severe. And this whole thought process where if it's dry, it's mild, and if it's wet, it's severe, it's changing very, very quickly because of our understanding of the pathophysiology and also new treatments that we can provide patients with dry and some of the more advanced forms of dry as well.
I think some of these studies that have come out about the vision loss associated with geographic atrophy, it does take me by surprise because, again, I've historically had this mindset of like, oh, wet, that's the vision loss patients. But there was a cohort study recently published of 1,900 patients with geographic atrophy. 66.7% went on to lose their driver's license within 2 years of their diagnosis. So these are people that are losing functional vision. It's completely changing their life. They had geographic atrophy as the cause of that, which in the past we've had zero treatment for. There would have been nothing for an eye care provider to do. And it's, something that we really need to be aware of. This is fast progressive vision loss, actually.
Yeah, and Jen, you bring up such good points here. We I think in eye care we become a little bit numb to it because we're talking about this. We're seeing this on a daily basis. Now let's take a step out of our shoes, our clinical shoes, and let's just go to the general public and let's ask them questions. And if we ask the general public, hey, you have five senses, which one would you be most concerned if you lost today? Sight is always number one on any study that you ever look at anywhere. When you just think about that one little thing, you reframe the way personally for myself. I know because we're so used to processes that we sometimes forget about the influence that we have on our patients. So I have to even remind myself too, because I'm a very process guy. So when I'm walking into these exam rooms, I have to remember what we're working with and what we're dealing with, and the fact that we're dealing with patients' most valuable sense. Saying that, Jen, I think that means we always have to have our antenna up. I think it means that we almost have to have an extra level of guard. We always need to be thinking about how can we catch even the smallest forms of GA sooner, and how can we be better so that we can get these patients established for appropriate care patterns for when technologies do become available that can treat these patients and ultimately slow it down. That's what we're doing. Unfortunately, we can't stop anything, but we can at least slow it down now and give these individuals hope. And like you said, that statistic is startling, but unfortunately not surprising. You and I are both aware of that. But we can now at least maybe give them a little bit more time of functional vision.